So for this question, we have a 45-year-old male come to the clinic due to muscle weakness over the past 5 months. The exam shows drooping of his eyelids. What will confirm the diagnosis? Is it A, edrophonium, B, propranolol, C, sertraline, or D, atropine? I'll let you answer the question and then I'll explain. Okay, so the answer is A, edrophonium. So edrophonium, first of all, that's the treatment for myasthenia gravis, which is what this patient has. So first you have to identify just the long-term problem that this patient is having, which is muscle weakness. So in that case, you should have your radar up for myasthenia gravis. And then the second thing is the eyelid drooping. So that once again clues you into the fact that it could be myasthenia gravis. And then you have to know the mechanism of action or the pathophysiology of myasthenia gravis, which is going to be antibodies to postsynaptic acetylcholine receptors. So essentially you have your own antibodies attacking the receptors on the postsynapse. And so what happens is if these receptors are all dying, well, acetylcholine is used to contract the muscle. So if acetylcholine can't bind to it anymore, well, now suddenly you're going to have muscle weakness because this whole acetylcholine can't get to the receptors anymore because they're gone, because they've been attacked and destroyed by your own antibodies. So this test is giving edrophonium, which itself is an acetylcholine esterase inhibitor. So just reviewing this pathophysiology. So we have acetylcholine, like I was saying, going and hitting the receptor, causing muscle contraction, which leads ultimately to muscle contraction. And what happens is acetylcholine esterase usually degrades acetylcholine, so it's not there forever. So edrophonium is something that inhibits this enzyme. So it's going to inhibit acetylcholine esterase. So if you inhibit this, any acetylcholine here will be left over, and so now you're going to get a surplus of acetylcholine, and so whatever receptors are left will be overactivated, and so the patient should have an improvement of their symptoms. So if that does occur, then your diagnosis of myasthenia gravis is much higher, and so that's why we use this test. And so going over the other answer choices, we have atropine. So this is going to be a muscarinic acetylcholine receptor blocker. So remember that the other one was nicotinic, but this one is going to be muscarinic. And so for muscarinic acetylcholine receptor blockers, we typically use them for bradycardia, which is just slow heart rate. So how this one works is you have the vagus nerve, which is cranial nerve 10, going down to the SA node in your heart. And so at the end, you have acetylcholine coming off of the vagus nerve and inhibiting the SA node. And remember, the SA node is what helps set the rate of the heart. And so if you essentially block this, now you're going to block the SA node from firing. And so this way, you're going to slow down the heart because it's not getting as much signal anymore. And so moving on, we have propranolol, which is a beta blocker. And so beta blockers are typically used for hypertension, high blood pressure, and migraines. And moving on to sertraline. Sertraline is going to be an SSRI, which just stands for selective serotonin reuptake inhibitor. And so these are typically used for depression and can be used off-label for other different disorders, psychiatric disorders to be specific. And so in summary, to talk about this, essentially you had to recognize this long-term problem, which is a muscle weakness over 5 months, and then this exam finding of drooping eyelids, and then realize that they're cluing you into myasthenia gravis, and then the test for myasthenia gravis is going to be edrophonium, and then knowing a little bit about how edrophonium works really helps lock that knowledge in. So I hope that helped, and thanks for watching.